Dr. Jay Kelkar, who is an eminent surgeon from Pune, from NIO, National Institute of Ophthalmology. She's a prolific pediatric ophthalmologist as well. So, Madam will be speaking about the diabetic retinopathy and the cataract. Which one comes first? Whether to treat diabetic macular edema or cataract and then diabetic macular edema, or both with together. Over to you, Madam.
Okay. At the outset, I would like to thank Dr. Srinivas Joshi for including me in this topic where all the vitreoretinal surgeons are doling out the expertise. So I feel like an outsider. But cataract is a problem which is being tackled by anterior and posterior segment surgeons alike. And though as anterior segment surgeons, we don't have to treat the retina, we should definitely be knowing what exactly is happening in the retina. So there is a growing tendency towards earlier cataract surgery in patients with diabetes, and they want improved visual outcomes. So delaying cataract surgery in patients with significant cataract, where it is not possible to identify or adequately treat the DME before cataract, can lead to poor outcomes. So when cataract surgery is undertaken before lens opacities obscure the macular assessment, the risk of DME is less, and that leads to a better visual outcome. So what are the preoperative considerations? Patients should have a good glycemic control. Avoid surgery in presence of ocular or periocular infection, obviously. Macular edema should be adequately treated before surgery, as pre-existing maculopathy aggravates post-operatively. Patients with pre-existing untreated PDR are more likely to progress and develop vitreous hemorrhage. So best would be to refer these cases to your vitreoretinal colleagues and get a PRP, it's recommended. In patients with pre-existing DME prior to treatment for the same, cataract surgery can increase the risk of progression or a redevelopment of macular edema to 20 to 50%. So perioperative intravitreal steroids, anti-VEGF agents are good options in these cases. So what is the effect of cataract surgery on retinopathy? So there are several conflicting evidences in literature. Some studies say that diabetic retinopathy progresses after phaco, while some have reported no significant change. Squirrel et al. Have shown an increase in the risk of DR progression following cataract surgery in patients with elevated HbA1c. In a retrospective study, Krepler found out that diabetic retinopathy was associated with male sex, disease duration, and poor glycemic control. So to differentiate between the effect of cataract from natural course of the disease, Dollar et al. Did a huge study, prospective study, showing that uncomplicated phaco cataract surgery does not accelerate the progression. Similarly, Shah and Chen also found that there is no increase in worsening of the diabetic retinopathy. However, the ETDRS study suggested a trend toward increasing retinopathy progression and worsening, and Dennison also reported the same in a huge cohort of patients in the UK. So what is the rationale behind the progression? So uneventful excellent cataract surgery also results in increased inflammatory cytokines in the eye. Patel et al. Reported that day one after uneventful phaco and IOL implantation, there were significant increases in the VEGF and the hepatocyte growth factor, the interleukin-1, and the pigment epithelium-derived growth factor concentrations. And these tend to increase up to 1 month and then decline in the postoperative periods. These cytokines induce clinical and subclinical worsening of the diabetic retinopathy and the maculopathy. So what is the effect of cataract surgery on macular edema? So from the results from the key findings of the UK EMR users group, they found there's a sharp increase in treatment requiring DME peaking at 3 to 6 months post-surgery. So the annualized DME rates from 0 to 3 months were 5.2 to 9.1, they went to 4%. So what are the indicators of poor outcomes following cataract surgery? So according to the ETDRS, it's presence of CSME at the time of cataract surgery. So a significantly poor vision is a predictor of final poor vision after surgery. Also, you must always correlate the amount of cataract with the amount of visual loss that the patient has, so that you can differentiate how much of it is because of cataract and how much of it is because of the retinopathy. The severity of diabetic retinopathy at the time of surgery plays a huge role. So treatment-naive PDR before cataract surgery may progress to vitreous hemorrhage and TRD following phaco, thus threatens good visual outcome. So visual prognosis, patients will always ask you, okay, how will I fare after? What do I expect? Should I be using premium IOLs? So cataract surgery in diabetes tends to report a lower incidence of complications, and there are better results because better pre-op management, because of evolutions in the operative techniques, better glycemic and hypertensive control, and of course because we are getting better and better at phaco. But diabetic patients with little or no retinopathy, you can give a good visual prognosis similar to those individuals without diabetes. The presence of DME and preoperatively poor visual acuity are definitely poor markers. And overall, the visual recovery after uncomplicated phaco is governed by macular perfusion status, the presence of macular edema, and the stage of diabetic retinopathy. So to conclude, the number of people with diabetes is increasing exponentially, so it is not the prerogative of only the vitreoretinal surgeon to be treating those. As anterior segment surgeons, we should be aware when we enter the eye, what all complications are we subjecting the patient to. Since we have all read Payman, and he had said that there is a protective effect afforded by the natural crystalline lens in progression of diabetic retinopathy. So as soon as that protective effect is lost because of cataract surgery, definitely there will be progression in the diabetic retinopathy status, and we should all be well aware of that. However, modern surgical and pharmacological therapies allow for safer and effective surgery, and emphasis should be on patient education, and special attention should be given to systemic and ocular conditions. Thank you.
Thank you. Thank you, madam.